It takes a little while to organize, so I'm really hoping that you started already. Did you start? And you looked through all that stuff? If you didn't, you're probably going to be uncomfortable on Thursday. Cardiovascular system is logical but complicated. It's a bunch of little logic relationships, each of which will make sense if you let them. But the complexity of the whole damn thing looks like this, right? Okay, so if your brain doesn't work this way, you don't have to look at this, right? I love concept maps. It made me so happy. And I actually made this for myself. And then my students eventually started asking for it. Did anybody look through it and go through it? Does it work for anybody else's brain? Okay, good. It works for my brain. By the way, this is an app that you can buy, and you can fold and unfold the nodes if you have the app. If you don't, you can just use the PDF. But if you want the app, I will send you the MindNode file so that you can play with it yourself. But this is one way to look at it. The worksheet that I gave you is another way to look at it. And the worksheet is a good way to figure out whether you understand all of those individual logic relationships, right? If this increases, what happens to this? If this decreases, what happens to this? Okay, so what am I going to do as far as testing? Well, I'm not going to say, hey, I need you to describe this whole damn thing to me. But you should, for instance, be able to explain the relationship between afterload and stroke volume, because that's one little logic relationship, right? And you should separately be able to explain the relationship between stroke volume and cardiac output, right? So if you understand the little logic relationships, then you should be doing okay, right? Collectively, it's a big complicated story. I'm not going to ask you to write me an essay about cardiovascular control. No, because I don't want to grade that crap, first off. Okay, so where we were last time is we did this, right? We did EDV, right? And its relationship to stroke volume. We did afterload and its relationship to stroke volume, right? But we didn't do this one yet, which is ventricular contractility. So let's go to this figure that was from your textbook, okay? Hopefully you guys remember. Where does afterload occur? Where? Where does afterload occur? Go ahead. You got it. What kind of vessels? Arteries, good, yes. It occurs in the arteries. Everybody okay with that? And you know that increased afterload will do what to your stroke volume? Decreased stroke volume, yes, okay, everybody's good with that. And then the place that most people have trouble, and I'm going to tell you because I don't want you to have trouble with, is they have trouble with end diastolic ventricular volume, mostly because they don't like to learn the vocabulary, okay? So end diastolic ventricular volume, of course, occurs where? Anatomically, where? Yeah, exactly. It's in the ventricles. That's why I call it end diastolic ventricular volume instead of just end diastolic volume. A, I learned it that way, and B, it makes more sense. It makes you like pay attention to what you're doing. End diastolic ventricular volume has primarily to do with how much the blood is returning to the heart, right? Venous return, and then what the atria are doing to get the blood from the atrium to the ventricle, right? And so that also has to do with Starling's law. Who can explain Starling's law to me? Are you going to try, Rejoice? I'll let Abel try if you don't try. No, you're not going to try? Okay, you want to try?
As stuff comes back into the heart, stuff must go out the heart.
That's great. And the mechanism, stuff comes in, stuff goes out. Yes. Done with physiology right there. And the mechanism is basically stretch your sarcomeres, right? Stretch your sarcomeres to a more optimal length, and then they will actually contract better. That's Starling's law. Okay. Related to that, but different, is this one that we haven't talked about yet, which is ventricular contractility. So I need you to listen to this because it's really easy to confuse with Starling's law, okay? But I don't want you to confuse it. Okay, so ventricular contractility is how hard your ventricles contract, but, and this is the important part, ventricular contractility is holding EDV constant, so we're not changing EDV. So there's no more in. There's a mechanism to get more out without having more in. You with me? Okay, so ventricular contractility, hold the EDV constant and increase the force with which the ventricles contract, and you will get more out. How do you do that? You do that with the sympathetic nervous system, because look, okay, sympathetic nervous system, so stick with me for a second. Here we go. Sympathetic nervous system comes from the thoracic region of the spinal cord, and you already knew that, right? and it goes to the SA node and the AV node. That will control rate. But now look, the sympathetic also goes to the wall of the ventricle. So now I'm going to tell you something new that you might not have known about the sympathetic nervous system. It can increase heart rate, but it also can increase the force of ventricular contraction. Yes? And that is holding the volume in the ventricles constant and just making them contract harder, right? So, everybody okay with that? So, the ventricular contraction, the sympathetic nervous system increases not just heart rate, but also strength of contraction. So, sympathetic nervous system hits cardiac output two ways, right? Heart rate and strength of contraction, okay? Now, how about circulating epi? Does circulating epi do the same thing? Yeah. It doesn't matter how it got there, right? It would also increase strength of contraction. So this is called ventricular contractility. So let's look back here and say, okay, this one. Okay, increased sympathetic nervous system activity will increase ventricular contractility, not to do with EDV, right? Not directly related to EDV, which will increase stroke volume. Or let's look at this diagram. Okay, look at this diagram. Trying to get it a million different ways into your head, whatever the hell works for your brain. Okay, what I'm doing here is holding EDV constant, do you see? Not changing that level. And what I am doing is increasing sympathetic activity to cause an increase in stroke volume, or decreasing sympathetic activity to cause a decrease in stroke volume. Does that make sense? I'm not changing EDV, okay? So if your sympathetic nervous system activates, it will actually cause an increase in heart rate, which we've already known, and it will also cause an increase in the force with which the ventricles contract. Is that okay? Go ahead.
More force, more strength per squish?
Yes, exactly. More strength per squish. Abel's going to basically translate for me today. You keep doing that, right? You got it? Okay, so somebody in your words, not Abel, somebody else, okay? I love you. You're great. I want somebody else to see if they get it. Somebody explain the difference between ventricular contractility and Starling's law. I will be so nice to you if you try, because you are so brave. Rejoice is tempted, but not very tempted. Ventricular contractility and Starling's law. Go ahead.
So you said you're going to be so nice.
I am going to. I'll help you. As soon as you get going, I'm going to start helping you.
So with Starling's law, it basically what goes into the heart is able to come out of the heart as well.
Mm-hmm.
But with ventricular, there is more going in and not going out.
No, it's the other way. The first part was right. Starling's law says more blood in stretches so that it works better and you get more blood out. Ventricular contractility, hold the amount of blood in constant, yes? Squish the ventricles harder and get it out. Does that make sense? Got it? Go ahead.
Starling's law, hose going out, constant, you don't change anything.
Mm-hmm.
Ventricular contractility, squish the hose faster, but it's still
Squish the hose.
You squish it so that more force comes
Oh,
out.
I
It's still the
see.
same
Yeah.
volume coming out.
Huh. That one's okay. Okay. So I'm going to tell you that you might need to go back and listen to this, right? And look at it. It's not super bad, but you have to. This vocabulary gets people. The whole ADV, Starling's law, ventricular contractility, but it's just vocabulary, and the concepts you totally can get. So spend a little time with it, and you'll be okay. Okay. All right. So what we just did is stroke volume. So we said there's basically 3 different ways to manipulate stroke volume. You got afterload, you got EDV, and you got ventricular contractility. 3 ways. Yes? Okay. And there's only one of those 3 that will always decrease stroke volume. What is it? Afterload. Good. Got it. Okay. Now, we're about to move to the other part of cardiac output. You guys tell me the equation for cardiac output. What is it? Yeah. Cardiac output equals heart rate, which we haven't done yet, but it'll be easy because you guys mostly know about stroke. And stroke volume. Okay. We just did stroke volume. So you guys tell me, of course, if I had a heart attack and my stroke volume really failed because the muscle is failing, right? What is my body going to do to try to maintain cardiac output and blood flow? It's going to increase your heart rate, okay? So that's the next place we're going to go. We're going to look at ways to manipulate your heart rate, okay? And this is going to be okay because you've done a lot of heart rate before too. And it's mostly sympathetic and parasympathetic nervous system, right? That's primarily how you manipulate heart rate. So let's talk about it. So factors impacting heart rate and therefore impacting cardiac output is going to be autonomic nervous system control. So autonomic nervous system control of heart rate, and then hormones controlling heart rate, and then just a couple of other little weird things, okay? This is not going to be bad for you because you already know what the autonomic nervous system does for the heart rate, right? So let's just go back and look at it. Okay, so autonomic nervous system. Here we go. Same picture that we looked at before. Your autonomic nervous system is going to control your heart rate. But do you remember which part of your brain decides whether to increase or decrease your heart rate? Do you remember? Medulla oblongata. Okay, so here's the deal. Just to put this together to make it one big story. Your brain, globally, is assessing the situation. Some of it conscious, most of it unconscious. But let's just say consciously right now, you're assessing the situation and you're saying, okay, everything's cool. And then what's going to happen is collectively everything's cool is going to go to your medulla oblongata, and then your medulla oblongata will decide whether to activate the sympathetic or the parasympathetic nervous system. And in this situation, what's it going to do? Everything's cool. You're going to activate the parasympathetic nervous system. Tiger walks into the room. Everything is not cool, right? And your brain is collectively going to tell your medulla oblongata to activate which one? Sympathetic. Okay. Now we'll talk about the fact that it's not just tigers today. But so stuff that you've learned before, medulla oblongata, specifically the gray matter within the medulla oblongata that gets to decide subconsciously. It's called the medullary cardiovascular control centers. That's okay, right? It's long, but it means what it sounds like. Medullary medulla, cardiovascular, heart and vessels, control centers, decide, okay? And they are going to regulate cardiac muscle contraction and vasoconstriction and vasodilation. Okay, so part of the medullary cardiovascular control center is hooked up to the sympathetic nervous system. Not surprisingly, that is called the cardioacceleratory center. Because what does it generally do? Increases your heart rate. The one that's hooked up to the parasympathetic nervous system is called the cardioinhibitory center. Is that okay? Okay, so let's talk about what the cardioacceleratory center does. You already know. It is going to send an impulse along the sympathetic nervous system, right? It's going to go to the SA node and the AV node because we're talking about controlling heart rate, okay? It's going to release what neurotransmitter? You know. Norepinephrine, good. And it's going to bind to what kind of receptors on the heart? Adrenergic, but specifically the ones on the heart are beta adrenergic. Yeah, the beta adrenergic receptors, like beta blockers, you can use to slow down your heart rate to drop your blood pressure. So it's going to go to the SA node and the AV node. Beta adrenergic receptors are involved. Administering epi in a clinical situation will have the same effect. So why I know Pulp Fiction is so old that a lot of you youngsters haven't seen it, but you should go see it. You should download it, whatever the hell you do. What happened is she actually had a drug overdose, right? And which caused massive vasodilation, which sent her into shock. So why you take a big old thing of epi and punch it in? Well, what it's going to do is administering epi is going to increase your heart rate, yes. It's also going to cause vasoconstriction, which will pump up your pressure. And remember now that epi, no matter how you get there, will also increase stroke volume because it's going to cause the ventricles to contract, right? So it's a triple whammy to increase your blood pressure, right? That's why it works. That's why you carry an EpiPen if you are somebody who is predisposed to anaphylactic shock because of peanuts or peas or whatever the hell, right? Yeah, it's an EpiPen. Yeah. One of those aha moments. I love aha moments. You're like, oh my God, did everybody know this? Shit. Yeah, it's an EpiPen. Okay, good. All right, so part of the medullary cardiovascular center is connected to the parasympathetic nervous system. That's the cardioinhibitory center. You know this. Sends impulses via the parasympathetic nervous system. Do you guys remember what nerve? Vagus nerve. Okay, that's the only one that I care about you knowing the name of in this story. The vagus nerve is pretty damn important. Parasympathetic goes to SA node and AV node. But please note, look, parasympathetic goes to SA node and AV node. Does it go to the wall of the ventricle? No. Parasympathetic nervous system has no direct impact on stroke volume. Only sympathetic has direct impact on stroke volume. Okay? So what it's going to do is You are assessing the situation, everything's cool, and you are going to release what neurotransmitter? Acetylcholine, yeah, onto the surface of the heart, and it's going to decrease your heart rate with no direct impact on the stroke volume. What type of receptors are involved for acetylcholine? Yes, cholinergic. Okay, so normally parasympathetic stimulation dominates, like it's most of the time in control of your heart rate. So if you cut all autonomic nerves, your heart rate will go up to about 100 beats per minute because that's the rate at which your SA node depolarizes. So now I'm going to tell you something, and we're about to cover it in just a minute. We've been talking about fight or flight and exercise as the reasons that you turn on the sympathetic nervous system. They are not the only reasons that you turn on the sympathetic nervous system. You turn it on for lots of reasons. It just makes a better story when I get you guys to understand fight or flight and feed or breed to start with. But I'm going to give you I want you to predict for me. You are also, for instance, assessing pressure at your aortic arch and deciding, based on that sensory input from the pressure at your aortic arch, whether to turn on the sympathetic or the parasympathetic nervous system. So predict for me before we actually go through this. If I detect high pressure in the aortic arch sensory receptor, right, I'm going to send that information to the medulla oblongata, and the medulla oblongata is going to turn on what? Sympathetic or parasympathetic nervous system? Parasympathetic, yeah? It's just a little negative feedback loop. Good? Okay. I'm also detecting the chemical content of my systemic arterial blood. So now, aortic arch, let me assess this. Let me assess oxygen and carbon dioxide, okay? And then use that sensory input to decide which one to turn on. You with me? At my aortic arch, I'm going to say, I am detecting low levels of oxygen, high levels of carbon dioxide. I'm going to send that sensory input to my medulla oblongata. My medulla oblongata is going to respond by stimulating what? More blood flow, yes? Okay, so now we're going to go through that in detail in just a minute, but now I'm just telling you that it's already wired up. You can use it for all kinds of negative feedback regulation, right? The sympathetic and the parasympathetic nervous system. Okay, we'll come back to that in just a minute. Okay, so basically what we just said is the autonomic nervous system controls the heart rate by deciding sympathetic and parasympathetic, and you know the neurotransmitters. Now, hormonal control of heart rate, you already know most of these too. Well, you know them. You might not have thought about the impact of them. Okay, so hormonal control of heart rate, epi, is the primary thing. Hormonal epi, right? And you know where it's released from, or else you're going to flunk on Thursday. Where does epi come from? Adrenal medulla. Adrenal medulla. Yes, it comes from the adrenal medulla during sympathetic activity. And what does it do? Well, however epi or norepi gets to the heart, it does the same thing. It increases heart rate and strength of contraction. Good? Now, thyroid hormone, T3 and T4. T3 is more active, even though I want it to be T4. Increase the metabolic activity of all tissues. So what do you think, for instance, somebody who has Graves' disease could expect about their heart rate compared to somebody who doesn't? Yeah, it's a little higher for a very long period of time. Somebody who has hypothyroidism, what could you expect about their heart rate? A little bit lower. Now, I'm not saying that thyroid hormone is used as a regulatory mechanism for heart rate, but thyroid hormone will impact heart rate. Good? Okay, so that's T3 and T4. Other factors that influence heart rate, so other factors that influence heart rate, just things that you know. Your emotions can turn on your sympathetic or parasympathetic nervous system, right? You know that, right? Emotional impact on heart rate. Have you ever, like, nothing is happening, your heart rate just goes through the roof because of just something that you, like, noticed or experienced, right? I mean, that's like adult life, right? Oh, or last night, for realizing when I was trying to sleep that I forgot to send an email to my boss that I was supposed to send over the weekend. Heart rate goes through the roof, right? Whoopsie. Okay, so emotion doesn't. How about temperature? If depolarization of cardiac muscle all begins with diffusion, and it does, right? Sodium and calcium, right? Then what do you think diffusion, what do you think temperature does to diffusion? Higher temperature, faster diffusion, lower temperature, slower diffusion. So basically at higher temperatures, your heart rate's going to be a little higher. At lower temperatures, your heart rate's going to be a little lower, right? But that's okay because at lower temperatures, in addition to your heart rate being lower, your metabolic needs are also a little lower, right? So, for instance, if you're going to drown in cold water, right? Because even though your heart is going to stop, your brain is also not going to need as much oxygen, right? But don't drown. Okay. So the other ones are also true. If potassium and sodium and calcium are the biggies for causing cardiac muscle contraction, then you won't have normal cardiac muscle contraction if any of those is abnormal. Because you know that, of course, hyper and hypokalemia affect heart, both of them do, right? But then sodium and calcium are going to affect action potentials in all tissues, right? And if you got action potentials here, you have to have normal ion composition to have normal cardiac muscle contraction. I'm not going to go back and test you over like hyper and hypokalemia, but and then last but not least here, the other thing that impacts your heart rate is endurance training. So why Lance Armstrong again? Why is his heart rate so low? Well, because his stroke volume is so high, right? So his heart rate can be low. So endurance training drops your heart rate because it increases your stroke volume. Go ahead.
So when this happens with seemingly no trigger, is that anxiety?
Yes. Mm-hmm. Yeah, anxiety is basically really broad definition, but like a panic attack. I don't have a tiger in the room, but my physiology is behaving as if I did, right? The physiology is the same, right? It doesn't matter whether there's an actual tiger or your perception of a tiger in the room. It is a real measurable physiological change in the body. That's what happens in those situations. Okay, so here's what we're going to do today to make sure that we get through the normal phys, okay? We are going to skip the clinical stuff, all the patho, unless we have time at the end, and then I will go through some of the patho. That also means that if I don't go through the patho, I won't test you on the patho, right? So we have to get through the normal phys, right? So if we have time, we'll come back to that one, but we're not going to do it right now. Okay, so now let's talk about mechanisms of controlling blood pressure. So blood pressure, okay? So let's back up a little bit and remind me that we talked about at the beginning of this set of notes that there's basically 3 ways to manipulate blood pressure. Blood pressure is one of the things that is the determinant of blood flow. It's not the only one, right? So 3 places or 3 ways to manipulate blood pressure. What are they? Heart, kidneys, vessels. You got it. The other class was like, I don't even know what the hell you're talking about. I swear I've said that like 10 times. Okay, heart, vessels, kidneys. Okay, so now what we are going to do is look at how you manipulate your blood pressure with your heart, your vessels, and your kidneys. Cool? Okay, and so first we are going to talk about extrinsic control of blood pressure. So here's what we're going to do. We're going to be controlling blood pressure with other body systems. We're going to control blood pressure with the nervous system, with the endocrine system, and with the kidneys. Okay, everybody okay with that? Okay, so extrinsic control of blood pressure, remember, is using one body system to control another one. Nervous, endocrine, and renal control, and we're going to go through each one of those. And then we're going to talk about intrinsic control of blood pressure, which will primarily just be paracrine agents, right? Paracrine agents doing local control. Okay, so let's talk about extrinsic control of blood pressure. All right, so this will go back to the autonomic nervous system again. How do you control blood pressure? You control it with the autonomic nervous system. But before we go any further, let's talk about what the autonomic nervous system could do to blood pressure. The autonomic nervous system, if it controls heart and vessels, and we're doing it with the nervous system, it's never going to undo what it does in one place with what it does in the other place, right? So, stick with me. If the sympathetic nervous system decides for whatever the heck reason to increase your heart rate, what is the only thing that it can do with your vessels that is consistent? Vasoconstrict. Okay. You guys with me? Okay. Because if I tried to increase my heart rate and then vasodilated, can you see that I basically just undid what I did the first time? I just increased the pressure and then dropped the pressure. Yes? So when we are talking about vasoconstriction here, we are talking about systemic vasoconstriction, which has more to do with generating pressure gradients than it does to do with impeding flow. Does that make sense? Go ahead, Abel. I don't know what I just said. I never know what I said. Okay. All right. So if we're doing extrinsic regulation, we're trying to affect the whole body system, either with hormones or with the nervous system, right? We're not doing something local. right? And so if I have a nervous system reason to increase my heart rate, yes? And so I increase my heart rate with the nervous system, with the sympathetic nervous system. Can you see that if I vasodilated when I did that, I would have just undid the pressure that I generated? Okay, so in this whole thing, until I tell you to completely change gears, you're talking about systemic regulation, the whole body system at a time, right? Okay, so if I decrease my heart rate, what's the only consistent thing that I could do with my vessels systemically? Dilation. Okay, you with me? Okay, so let's go through this. All right, so now, autonomic nervous system. So what I want to talk about is, other than tigers, what is the other sensory input that you use to decide whether to turn on your sympathetic or parasympathetic nervous system? So what we are going to talk about is baroreceptors, which are pressure receptors, and then we're going to talk about chemoreceptors, which are chemical receptors. Good? Okay, so here we go. Sensory input in. All right, so let's talk about where you are actually monitoring sensory pressure in your system. Okay, so there are two places that you are monitoring pressure in your system, in your arteries, and that is in the aortic arch, which is delivering blood flow to almost all of the systemic circulation, right? So you got baroreceptors here in the wall of the aortic arch. You've also got baroreceptors in the carotid sinus. And the carotid sinus is really important because the internal carotid arteries deliver 75% of blood supply to where? Brain. So these are going to do the same thing. This one is way easier to piss off. Okay? Okay. So you guys can predict, if I, for instance, detected low pressure here, I would probably activate which? Sympathetic or parasympathetic nervous system? So yeah, I need more blood to my brain, right? If I detected high pressure there, I would probably activate the parasympathetic nervous system, right? So what I'm telling you is there is sensory input in that is used, in addition to tigers, to figure out whether to turn on the sympathetic or parasympathetic nervous system, okay? So let's talk about these. These are called baroreceptors, pressure receptors. And the primary places that you have them are in the carotid sinus and then in the aortic arch, okay? And those are both going to respond to systemic blood pressure. This one, by the way, is more susceptible to body position changes. So the aortic arch might not turn on when you're laying down, but this one will. And this one also does not play. It doesn't give a crap what happens to the other organs. If the brain needs more blood, we are going to activate the sympathetic nervous system, right? The brain has no equals, right? It is the highest among equals. It like decides what's going to happen with the body. Okay, but they're both going to do the same thing pretty much. Okay, so let's talk about how that's going to work. I'm going to show you guys an animation for that one. Okay, you ready? This is baroreceptor reflex control of blood pressure. This is the aortic arch, and that is not the carotid sinus. That's the brachiocephalic artery, but that's what happens when you have physiologists draw anatomy pictures. They make the adrenal gland like that big, and they don't know where the vessels are. They're trying to show you carotid sinus and aortic arch. Okay, so let's see.
Stretches the carotid arteries. Increased blood pressure stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation. Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata.
Okay, so that's just sensory input in. We haven't done any motor input out yet. So now your prediction for me. So I just really stretched the aortic arch and sensed that sensory input in, okay? Now, what am I going to do to the parasympathetic nervous system? What am I going to do to the parasympathetic nervous system? Increase or decrease its activity? Parasympathetic nervous system. Increase it. What am I going to do with the sympathetic nervous system? Decrease it, right? Does that make sense? Okay. All right, so let's see.
As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate.
So that's basically like putting your foot on the brake, right? I put my foot on the brake. Now what am I going to do to the gas? Well, I'm going to take my foot off the gas. Does that make sense? Okay.
Also, as a result of the increased stimulation from the baroreceptors, The cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume.
Okay, before he tells you, I want you to tell me, what can I do with the vessels that would be consistent? Dilate. Yes, vasodilate. Yeah? Okay.
The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal.
That's
If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
Okay, so let's do it the opposite way. You ready? This time I want you guys to help me figure out what's going to happen if I detect low pressure in the carotid sinus. Low pressure in the carotid sinus. Sensory input goes where to the brain? Medulla oblongata. And the medulla oblongata says low pressure in the carotid sinus. Now, what do I need to do to the parasympathetic nervous system? Parasympathetic first. Decrease parasympathetic stimulation. And then what do I need to do to the sympathetic nervous system? Increase sympathetic stimulation. What can I do that's consistent with the vessels? Constriction. Constriction. Good? Okay. You all right with that? Okay. It's all pretty logical. It's just a little negative feedback loop, right? Okay. All right. So here's the one that is a little counterintuitive. So if you weren't listening before, make sure you listen now. Okay. So these are what we call arterial baroreceptors because they exist in the arteries, right? The aortic arch and the carotid sinus. But now I'm going to tell you another kind of baroreceptor. And the other kind of baroreceptor is the right atrial baroreceptor. Okay, so stick with me for a second. Here we go. The arterial baroreceptors, let's think about it. Aren't they at the front end of systemic circulation? Front end? Do you see what I mean? Just front end of systemic circulation. The right atrium is at the back end of systemic circulation. You with me? Okay. So now this is counterintuitive until you sit and think about it for a second. I also have baroreceptors in the superior and inferior vena cava and the right atrium. Okay. They're going to respond at way lower pressure because those never get anywhere near as high pressure as the arteries, right? Okay, so here's what I want to talk about. If I detect high pressure in the right atrium and the superior and inferior vena cava, I have to decide whether to turn on the sympathetic or the parasympathetic nervous system. And does anybody want to hazard a guess as to which one would help that situation? Yeah, sympathetic. Okay. So I want you to think about this. So what's happening in the right atrium and the superior and inferior vena cava has more to do with venous return than it does arterial flow, correct? Okay. Now, if venous return is really high, what the heck do I need to do in my ventricles? I need to get to work, do I not? I need to get working, right? Because even if I slow them down, is that going to slow down venous return? No, it's not going to slow down venous return. So what's happening is I have so much blood in that if I slowed down the ventricles, it would back up into the capillary beds, right? It causes congestive heart failure. Is that okay? So what happens is if I'm detecting a whole bunch of pressure in the back end, I need the ventricles to keep up, right? So this is basically like traffic, right? I've got so much traffic. Do I want on the little on-ramp to the highway, I've got so much traffic going on the on-ramp. Do I want to have more red lights to keep me from getting on the on-ramp? No, you freaking turn it all green and let everybody go and fend for the damn selves, right? Just go, right? That makes sense? So now what we're going to see in the right atrial baroreceptor reflex is work through with me. The right atrial baroreceptor reflex says high pressure in the right atrium, the superior and inferior vena cava. Send that to the medulla oblongata. This time the medulla oblongata says high pressure in the back end of systemic circulation means I need to increase which? Sympathetic or parasympathetic nervous system? Sympathetic. So I've got so much coming in that I need to get to freaking work and get more out. Does that make sense? Okay. If I didn't, then I would cause more problems, right? Then I would just continue backing up. I would cause a huge traffic jam. Okay. So your job with atrial and arterial baroreceptor reflexes is to pay attention when I write the word atrial and arterial because they look really similar to one another, and you're going to respond to high pressure in the right atrium entirely differently than you would respond to high pressure in the arteries. Okay? And I generally, when I know it's a word that's easy for you guys to confuse, I will put it in bold or in all caps or underline it, but you have to read it. I don't know what the hell I can do for you if you don't read it. Okay? Does that make sense? Okay. So that is the right atrial reflex. and it's back end, okay? Now, the last thing here is to talk about, okay, so I said that I'm monitoring pressure, and I'm monitoring it in the arteries, aortic arch and carotid sinus. They pretty much do the same thing, only just it's easier to cross, right? I'm also monitoring it in the right atrium, right? But now I'm going to tell you that I'm also monitoring the chemical content of systemic arterial blood, the chemical content, okay? So, what kinds of chemistry am I going to monitor to figure out whether I need more blood flow? Well, not surprisingly, I'm going to monitor oxygen content, carbon dioxide content, and then also pH. Because I think you've seen this equation before. Have you seen this before? CO2 plus H2O yields H2CO3, which dissociates to H plus and HCO3 minus. That means that if you are not getting good blood flow and you're building up carbon dioxide, it's going to do what to your pH? Drop. Okay. So I'm monitoring those three things, okay, in the carotid sinus and the aortic arch. So let's talk about that and how it's going to actually respond. So you guys predict for me before I tell you, okay? Predict for me what's going to happen. If I detect low oxygen, high carbon dioxide, or low pH in the aortic arch, I'm going to send that impulse to the medulla oblongata, and the medulla oblongata should react by increasing which? The sympathetic or the parasympathetic nerves? Sympathetic. Good. That means we need more blood flow, not less blood flow. Good? Okay. So these are called chemoreceptors, and they're only in these locations. So here we go.
Chemoreceptors in the carotid and aortic bodies monitor blood oxygen, carbon dioxide, and pH. Impulses from these chemoreceptors are conducted to the control centers for heart and blood vessels via the glossopharyngeal and vagus nerves. Chemoreceptors in the medulla oblongata monitor blood carbon dioxide and pH. Decreased blood oxygen, increased carbon dioxide, or decreased pH, decreased parasympathetic stimulation of the heart.
Does that make sense? If that goes in, you decrease parasympathetic and you increase sympathetic, right? Okay, take your foot off the brake and then put your foot on the gas. Good? Okay.
Which increases the heart rate. Decreased blood oxygen, increased carbon dioxide, and decreased pH increase sympathetic stimulation of the heart, which increases heart rate and stroke volume.
Okay, before I tell you what happens to the vessels, I want you guys to tell me. So what can you do with the vessels that would be consistent? Constrict. Are you starting to get it? Yes? Okay.
Increased sympathetic stimulation of blood vessels increases vasoconstriction.
Everybody good? Okay. All right, so that is I think the chemoreceptor one is really easy to understand. Okay, it's not bad. Okay, so that's the chemoreceptor one. I think that both of those animations are on the links page, but they'll also be captured on this video. Okay. How many of you guys actually worked through stuff over the weekend? Did you work on the worksheet and or the concept map? Okay, good. Because if you didn't, you're going to have a hard time grasping this quickly enough. If you're going to start today, it's going to be a really rough 2 days for you. Okay, I will try to make the questions over the cardiovascular system very clearly worded, but you actually have to learn the words, right? Okay, so we just did nervous system control of heart rate. That's one extrinsic regulation. Nervous system control of blood pressure. That's one extrinsic. But now let's do hormonal control of blood pressure, right? Okay, hormonal control of blood pressure. So which hormones directly impact blood pressure? So let's talk about it. So you probably won't be surprised, but there are a whole bunch of different ways to increase your blood pressure and not very many ways to decrease it. Because can you see that, like, just like with blood glucose, right? There's like 10 ways to increase your blood glucose and only one way to decrease it. Quite often you need more blood flow and not less. So we will see that there are a whole bunch of different ways to increase blood pressure. So what we're going to do is go through these hormones, okay? But I don't think you have to memorize them. For instance, if you memorize that epi increases heart rates, everybody knows that by now, right? Do you have to memorize what it does to the vessels, or can you figure it out every damn time? You can figure it out. What could it do to the vessels that would be consistent? No, not that. Constrict, okay. So, okay, ADH. What does ADH do to blood volume? Increase, which does what's your blood pressure? Increase. Now, do you have to memorize what it does to the vessels, or can you just pick what's consistent? Picks what's consistent, right? If it increases blood volume, what the only thing that can do with vessels that would be consistent would be what? Constrict, okay? So you don't have to memorize all of this stuff. As long as you understand one of the targets, you can get the next one, okay? All right, so let's talk about the hormonal effects. Okay, from where? Don't you miss it this time. Adrenal medulla. Comes from the adrenal medulla. And the effect is increased cardiac output, because we know it increases both heart rate and stroke volume, right? That's what epi does, okay? And the only thing consistent for it to do with the vessels is what? Constrict. The impact on blood pressure, higher or lower? Higher, good, okay? ADH, where's it come from? Posterior pituitary. You know that there's endocrine on this test, right? You do know, right? Yeah, okay. Posterior pituitary. And so what does it do? It increases blood volume because it causes water retention, right? And the thing that it could do that is consistent with vessels is what? Constriction, okay? And that also goes to its other name. What's the other name of ADH? Vasopressin, exactly, good, okay? So what's the impact of ADH on your blood pressure? Increased blood pressure. Okay, angiotensin II, you probably don't know yet. I'm going to tell you a short version of what it does right now, and then I'll go back and tell you why it's released. Okay, where's it from? Put kidneys, but put an asterisk, because it's only kind of kidneys, and you'll see why in a minute. And it does two things. It's the most powerful vasoconstrictor in the body, and it causes aldosterone release. Do you guys remember what aldosterone does? Sodium retention and therefore water retention. So vasoconstriction and water retention will do what to your blood pressure? Increase your blood pressure. Good. Okay, I'll explain angiotensin II in more detail in just a second. Okay, aldosterone. Let's remind you what aldosterone does, because you have to know this for endocrine anyway. Here's what aldosterone does. At the kidney, this is aldosterone. Aldosterone. Okay. What it does is, here's the blood, here's the urine. Aldosterone causes sodium and therefore water retention at the expense of H plus or K plus. We don't care about those right now, but we sure care about this, right? So aldosterone increases water retention at the kidney, and sodium and water reabsorption at the kidney. And what's the impact on blood pressure? Higher, okay? Erythropoietin, don't know if you learned this in anatomy. I usually teach about it in anatomy. EPO comes from the kidney too. And what that one does is causes erythropoiesis. And erythropoiesis is red blood cell production. So just think about the blood volume being whatever it is and then stuffing it full of more stuff. What's that going to do to your blood pressure? It's going to increase it, right? It's going to increase. Okay, last one. ANP or ANF comes from where? Heart. Atrial natriuretic peptide or factor, whatever you want to call it. And this one is released in response to prolonged atrial wall stretching, okay? And its primary target is the kidneys, okay? And it's a diuretic. Does that make sense? So it decreases blood volume by making you pee more, okay? What can it do to the vessels that is consistent? Vasodilation. You got it. Yes, vasodilation. And so what's the impact collectively of vasodilation and diuretic? Decreased blood pressure. Yeah, good? Okay, all right. So here's your tip, guys. Avoid memorization whenever you can, because a hormone that decreases blood pressure can do it by one or a combination of these three ways. It can do, so did I say decrease blood pressure? Let's do increase first. Hormone that increases blood pressure can do it in one of any, or any combination of these ways. Vasoconstriction, yes, increased cardiac output, or increased blood volume. If you're going to do the opposite, then you can do vasodilation, decrease cardiac output, decrease blood volume, right? So if you memorize one target, you don't have to memorize two, right? Okay. Alcohol. Let's talk about alcohol. What does alcohol have to do with this story? Alcohol is a diuretic, but it's a diuretic for a specific reason, because it's actually an anti-diuretic. It decreases the release of ADH from the posterior pituitary, right? And if you don't release ADH, you pee more. Yes? Okay. So what does it do to your blood pressure? Short-term, small quantities of alcohol. I'm not talking about being an alcoholic. What does it do to your blood pressure? It drops your blood pressure, right? And it also does it by another mechanism. So it does it by another mechanism because it actually inhibits the vasomotor center in the medulla oblongata and allows for vasodilation. So take a sip of wine, right? Give yourself a minute. You feel your blood pressure drop. Yeah, you do. Just like 10 minutes after taking a benzo, right? You feel your blood pressure drop. It drops your blood pressure. It's never a popular thing to say in Utah, but small quantities of alcohol are better for a cardiovascular system than zero alcohol. And they're way better than a lot of alcohol. A lot of alcohol is a huge problem for your cardiovascular system. Okay, so you guys, I have a heart problem, and I have a heart murmur and atrial fibrillation. And my very, very LDS cardiologist told me that either I could be on this maintenance medication or I could have a glass of wine per day.
Let's guess which one you chose.
And I was like, I was already going to do that. Thanks. My mother-in-law literally did not believe that he said that, and so I took her with me the next time. She's like, yeah, it's medicine. I was like, medicine. Either that or I had to be on a pill every single day for the rest of my life. I was going to drink wine anyway. Huh? Okay. So now let's talk about renal control of blood pressure. Renal control of blood pressure is not a short-term fix, right? So if your blood pressure is too high and you have to pee out your blood volume, that is not going to fix it short-term. It's going to fix it long-term, right? Or if your blood pressure is too low and you actually need to retain more water, this is a long-term fix. I mean, not like years, but not seconds, right? It's a longer-term fix. So the direct way is your kidneys just determining how much water you keep versus lose, right? And then the indirect way is this mechanism that I'm about to teach you with the angiotensin II, okay? So this is a little relationship that I want to see if you guys can understand. I think you can. So nobody ever remembers this, but I know that I teach it in anatomy. So do you remember the juxtaglomerular apparatus in the kidneys? You're my favorite. Do you remember the juxtaglomerular apparatus? So basically there's this part of the kidney right next to each nephron, and including the afferent arterial, that is constantly monitoring pressure. Okay, the kidneys are a really good place to monitor pressure because they're super sensitive to pressure changes, right? Like kidney function is really dependent on pressure. Too low and they won't work. Too high and they'll bust, right? So the kidneys is one of the places that you monitor and respond to blood pressure changes. So, and specifically the juxtaglomerular apparatus, but I won't ask you that name yet. So here's what we're going to do. We are going to say, here is how the kidneys can respond to low pressure. So low blood pressure at the kidney, for those of you who care, it's specifically in the afferent arterial of each nephron, okay? What that is going to do is when low blood pressure is detected by these specific cells, I call them special cells, they're juxtaglomerular cells, but nobody wants to learn that name. So low blood pressure at the kidney causes the release of a hormone called renin. And renin interacts with the plasma protein, that protein in the blood plasma that's always around. It's made by the liver and it's just hanging out in the blood plasma, it's always around. So here's what it's going to do. This is Angiotensinogen, okay? This is made by the liver. It's always around, but it's not usually active because you don't always have renin. And what angiotensinogen is going to do is when renin is present, which only is present when the kidney releases it, you're going to take angiotensinogen as in the beginning of, and renin is going to convert it into angiotensin 1, which doesn't really get me anything. And then you're going to interact with another inactive plasma protein called ACE. ACE comes from the lungs. ACE stands for angiotensin converting enzyme. That's not hard, right? What it's going to do is convert angiotensin 1, angiotensin 2. Okay, so I'm going to give you a second to write that down, and then I want to talk about how that fixes the problem. So the problem was low blood pressure, yes? And what I just did by this little cascade is cause myself to release angiotensin 2. How's the angiotensin 2 going to fix the problem for me? Two ways. Yeah. Vasoconstriction. Yeah. And aldosterone release. Good? Mm-hmm. Okay. This looks complicated, but it's actually not. First of all, angiotensin basically means you are going to vasoconstrict. Angio meaning vessels and tense meaning constrict. Angiotensinogen is before angiotensin, as in Genesis, yeah? And then I go angiotensin 1 to angiotensin 2, right? So, last tidbit is why did I have you put an asterisk when I said that angiotensin 2 comes from the kidney? Because where does it actually come from? I don't know, kidney, liver, and lungs, of all freaking places, right? But it is a hormone, right? Because it goes into the bloodstream and has a bunch of different effects on a bunch of different places. I don't know where you would say it comes from. You don't get it unless you have things from all different organs. Do you see that even though this is always present from the liver and this is always present from the lungs, it's always in the bloodstream, they don't ever interact with one another unless the kidney triggers it. Does that make sense? Okay, so this is the renin-angiotensin-aldosterone system. Go ahead.
You wouldn't ever ask a question about biology.
Sure, I would. I just have to word it so that you actually can come up with the answer.
So with the answer you give me.
I wouldn't ask a simplified question for a complex answer.
What three systems?
Which three organs are involved in the renin-angiotensin-aldosterone system, right? So yeah, it's my job to write a clear question for you.
Okay.
Yeah, I know you think that I do, but I don't really try to trick you, right? Except bonus questions, then I try to trick you, right? Are we okay? It's really not that bad, guys. It's not terrible, okay? Okay, so angiotensin 2 is the most powerful vasoconstrictor in the body, and it causes the what to reduce. By the way, where does aldosterone come from? We didn't talk about that before. Yeah, adrenal cortex. That's where it comes from. Good. Okay. So it's just a weird little hormone system, but I still think it's a hormone. Don't you? Angiotensin 2 a hormone? Yeah, I think it is. Okay. All right. So what we just did was nervous system control of blood pressure. Yeah? Hormonal control of blood pressure, renal control of blood pressure. Yes? Okay. And now what I want to do is I want to change gears, and you have to change with me or else you're going to hate your life. And instead of talking about systemic control of blood pressure and blood flow, I want to talk about local control of blood pressure and blood flow. Yes? Local. So we're back at the situation where I am the arterial and you guys are the cells and capillaries. I am controlling blood flow too. Yes? So this can't involve the heart because that would go everywhere, right? And it's not going to involve the kidneys because that would change everything. Yes? So it only is going to control what? Local control of blood flow is only what? It's only vessels. Yes? Only vessels. Okay? So here's the deal. I'm going to try to change blood flow patterns to you guys. I am your arterial. You are the only capillary bed that I care about, right? I don't give a crap about any other capillary bed. I'm going to control blood flow to you based on your paracrine feedback to me, right? You tell me what you need, right? And then based on whether I think I need to protect you or not, okay? Now, I'm not trying to change systemic blood pressure because me as an arterial, I don't give a crap about the whole system. I only care about you guys, right? So if I do vasoconstriction, I'm not trying to change blood pressure. If I do vasodilation, I'm not trying to change blood pressure. I'm just trying to change blood flow to you guys, okay? So In this situation, it says at a given MAP, that's mean arterial pressure. It's jargon. All I'm talking about is I hold the pressure of the system relatively constant, right? At a given mean arterial pressure, you can regulate blood flow through your own capillary by telling the arterioles that feed you what you want, okay? So let's talk about what you would do. These changes may or may not impact mean arterial pressure, but that's not what they're trying to do. You're only trying to get more or less blood flow to you guys. Okay, so in a situation in which you guys are out there and you are working your butts off and you detect and tell me about low oxygen, high carbon dioxide, or low pH, you release paracrine agents and they should tell me to do what? You tell me, I'm your arterial that feeds you. You detect low oxygen, high carbon dioxide, or low pH. What should you tell me to do? Dilate. Yes. Please note that that is entirely different than what you would do if you detected that in the aortic arch. Yes? Because I am not controlling the entire system. I am only worried about this one little capillary bed, right? So I say vasodilate, and you guys want more stuff, and I'm going to give you more stuff, okay? So I'm going to give you more blood flow. So that is called metabolic control. Low oxygen, high carbon dioxide, or low pH will cause local dilation of arterioles because of release of paracrine agents. Okay? That is totally different than systemic regulation. Now, which would win if the two were battling? What do you think? Yeah, systemic will eventually win because it's got the freaking brain and the heart and the kidneys, right? But maybe the situation is like I talked to you guys about in the beginning. You guys are the liver, and I took too many acetaminophen or had 6 shots of tequila yesterday. I did not. Either one. But you guys are just hanging out, and you need more blood flow to the liver, but not in the entire cardiovascular system. That's when this would occur. Okay, and then there's another one that's called myogenic control. And myogenic control is me deciding when I have to protect you. So you are the only capillary bed that I care about. I am your arteriole. I am feeding you. And what I detect is high systemic blood pressure. And you can't protect yourselves, can you? You have no connective tissue and no smooth muscle in your walls. So what do I need to do to protect you if I detect high blood pressure? Constrict. Even if that adds to the problem, I don't care about any other capillary bed, only you. You guys are my homies, right? So I vasoconstrict even if it adds to the problem, right? Does that make sense? That's called myogenic control. And it's really trying to protect you guys from high pressure. Good? Okay. This is like the mama bear thing, right? I don't care about any of the other bears, only my bears, right? Everybody else can screw. Okay. Now, what about long-term control? What if you guys consistently start telling me over and over and over and over and over again that you are not getting adequate blood flow from your metabolism? Like, for instance, now you guys are the quadriceps femoris muscles, and you start training for a marathon, right? And so what you're going to need very, very regularly is lots more blood flow than you have in the past. Over long term, what can happen is if you release paracrine agents consistently often enough that tell me you need more blood flow, I will widen the vessels that feed you, and I will do angiogenesis, which is develop more blood vessels into the region. Does that make sense? It's called angiogenesis. You can actually develop more blood vessels into the region, right? More branching arterioles, more branching capillaries into the region. Is that okay? Okay. Does that make sense? Somebody nod, right? Yeah? Okay, good. Because some of you guys have very expressive faces. Abel always tells me when he's confused, just like, okay, oops. Okay. Now last little tidbit about just local blood flow is simply that there are a couple of places in your body that have the extremes of blood flow. There's one place in your body that always needs about the same amount of blood flow, whether you're asleep or awake. And what's that? The brain. There is another place in your body that needs vastly different amounts of blood depending on whether you're exercising or not. And that's skeletal muscle, right? Okay. So the thing I want to tell you is what is the trigger in skeletal muscles and what is the trigger in the brain that will cause vasoconstriction or vasodilation? Just local, right? Still doing local. So here's the deal. Blood flow to skeletal muscles is really dramatically different when you're exercising. They get active or exercise hyperemia, which means that when you're exercising, there's boatloads of blood flow going to your skeletal muscles, okay? What is the main stimulus that you guys are now skeletal muscle cells? You tell me when to vasodilate by telling me when you detect low oxygen. Yes? When you detect low oxygen, you send out paracrine agents that will cause me to vasodilate. Is that okay? Okay. Now, of course, you could, if that wasn't adequate, also say, hey, I need more than that. I need the sympathetic nervous system and the cardiac muscle to increase as well, right? But first, you guys will do the local thing. That's what you'll do first, okay? And then the brain gets super duper pissed off by too little blood flow because they call it neuronal intolerance of ischemia, which is a fancy way of saying that your neurons will die if they don't get enough blood. But in addition, your brain is also really intolerant of too much blood flow because there's no room for swelling, right? So it's like a Goldilocks situation. You have to get exactly the right amount of blood flow. So it's got a relatively constant blood flow, but the main stimulus for autoregulation is different than you'd expect it to be. I would expect it, the brain, you guys are brain cells now. What do you tell me that will make me vasodilate? Low oxygen doesn't really do it. What does it is high carbon dioxide or low pH because you guys have a buffering system. So you get pissed off about carbon dioxide and pH way before you get pissed off about oxygen. So as soon as you guys detect high carbon dioxide, you tell me you need more vasodilation. Okay, so we are going to skip variations in blood pressure because that's a patho situation, right? Unless we have time, and then we'll come back to it. And we are going to go to heartbeat coordination and the cardiac cycle. Cool? And if we have time for the patho, we'll come back to the patho. Okay. All right, so let's talk about what I hope you remember from anatomy, and then we will get to the rest. Okay. You guys should remember the basic anatomy of the pacemaker cells in the heart. You remember that the SA node is, of course, just inferior to the opening of the superior vena cava, right? And you remember that the AV node is in the interatrial septum at the bottom of the right atrium, right? And then this is the AV bundle, also called the bundle of His. What people misunderstand is this is not nervous tissue. I know it looks like it with the way that they draw it, but it's not. What it is this is a blob of pacemaker cells, you know, the ones that have that spontaneous depolarization. This is a chain of pacemaker cells stuck together with gap junctions. Good? Okay. So, and this is going to split into the left and right bundle branches, which go to the left and right ventricle. But none of these cells are talking to the contractile cells yet. You actually do not talk to the contractile cells until you get down to the Purkinje fibers, okay? So here's how this works, and here's something that you need to understand. The SA node will depolarize, send ions through the atria from the top to the bottom. So the atria are going to contract in what order? Top to bottom. Right about that you get to the right about the time you get to the bottom of the atrium, you will flood the AV node that was already on its way to depolarizing. You will flood it with sodium and calcium ions, and so you get to control it because the SA node always gets there before the AV does in a healthy person, okay? So the AV node was going to depolarize and cause contractions, but as it's on its way out the door, you tell it, hey, depolarize and cause a contraction. It's like, I was gonna, right? It's like you're on your way out with the garbage and you want credit for taking out the garbage, and then your mom says, hey, will you take out the garbage? And you're like, damn it, I was going to do it without being asked. That's the AV node's life, right? It's like, I was going to do it. Okay, but the AV node actually doesn't talk to contractile cells. It just sends its impulse to these guys, which don't talk to contractile cells. And then it sends its impulse to the left and right bundle branches, which don't talk to contractile cells. The only time you start talking to the contractile cells is with the Purkinje fibers. And so now, how are your ventricles going to contract? How are they going to contract? Bottom and sides up, right? And in addition, this whole business forces a lag time of about 0.2 of a second between atrial contraction and ventricular contraction. What's important that's happening between atrial contraction and ventricular contraction? Filling, yes, right? So this whole business forces lag time between atrial contraction and ventricular contraction. Good? If you didn't have this, then they would contract almost simultaneously and you wouldn't have time for filling. Is that okay? Okay, so hopefully you already understood that. So the SA node gets to be the boss because it hits its action potential slightly faster than the AV node. So it actually controls the AV node. So we'll do clinical applications if we can, but now I want to start with the cardiac cycle. Okay, so here's what we're going to be talking about with the cardiac cycle, and I've actually got an animation for you guys with this one too. what the cardiac cycle is trying to put together the electrical activity of the heart with the mechanical activity of the heart. So what do I mean by electrical activity? When do the chambers depolarize? That's electrical activity, right? Everybody okay with that? Okay. When do the chambers depolarize? That's electrical activity. Okay. And what's mechanical activity? Mechanical activity is when it wiggles or when the valves open and close. So mechanical activity would be when do the chambers contract versus relax, and when do the valves open versus close. So what we want to do with the cardiac cycle is we want to tell one story that puts together electrical and mechanical activity, right? Okay? So we know that the depolarization, for instance, of the atrium will cause what mechanical event? Do you know? It's either a contraction, relaxation, or a valve opening and closing. What is it? Depolarization of the atria will cause atrial contraction. Yes? Okay. Right? So what we're going to do is we're going to put together this story. We're going to figure out when the valves are opening and closing, when the chambers are relaxing and contracting, and what it has to do with the electrical activity. The good part about this is you already know all the parts. You just haven't put them all together yet, right? So this is a story that you already know, and you're just going to make sure that you understand the logic of the story. It's not new stuff. This is not new. Okay, so this is called the cardiac cycle. Okay, the cardiac cycle is represented by this image in your textbook. Okay, so let me introduce you to the 4 stages of the cardiac cycle, and then we'll talk about the details. You ready? Note this first phase is pretty long. That has to do with the length of the phase. This first phase is called ventricular filling. Now, just make that word make sense to you. If it's ventricular filling, you know something about the position of the AV valves, do you not? They have to be what? Open or closed. They have to be open if the ventricles are filling. FYI, you don't have to memorize the position of the semilunar valves. You never have both sets of valves open at the same time because that would compromise unidirectional flow of blood. So if the AV valves are open, the semilunar valves are closed. They have to be, okay? Now, so that is called ventricular filling. Ventricular filling is going to end when the ventricles start to contract, right? They're not going to contract anymore. When they contract, stick with me, guys. When they contract, what's going to happen is the valves are going to open, close. Some valves are going to do something. Ventricles are going to start to contract and they're full. What valves are going to do what first? AV valves are going to close, okay? Then I have this period, this teeny tiny period. Do you see this period right here? In which all of the valves are closed and the ventricles are contracting. That is called isovolumetric, because ain't nothing going nowhere, right? Isovolumetric ventricular contraction. Does that make sense to you? All of the valves are closed and the ventricles are contracting. So I want you to think about it. Isovolumetric ventricular contraction is going to end when what valves do what? Semilunar valves are going to open. Good, you got it, right? See, it's the same stuff that you knew. You're just putting a little bit more terminology to it. Semilunar valves are going to open. That begins the period of ventricular ejection. Notice it's pretty long, right? Ventricular ejection. Ventricular ejection, you are ejecting from the ventricles into what kind of vessels? Arteries. Yeah, you're ejecting from the ventricles into the arteries. Is that okay? Okay. Now, here we go. Ventricular ejection is occurring as the ventricles are contracting. Then the ventricles are empty now, right? And we're going to start to relax them. As I start to relax them, the ventricles are low pressure, the arteries are high pressure. The blood tries to go backwards, right? And gets caught in the cusps of which valves? Semilunar valves. It gets caught in the cusps of the semilunar valves, right? And that will cause the semilunar valves to close. Yes, okay? And that begins this brief period, notice it's pretty brief, of isovolumetric, because nothing's going anywhere, ventricular relaxation, right? You with me? And then we're going to be back at the beginning of the story again. And we're going to be back at the beginning of the story. And this is something that's really commonly misunderstood, so make sure that you understand this part. So I'm back at the beginning of the story, and now what I'm going to do, isovolumetric ventricular relaxation is going to end when what valves do what? AV valves open. Now, there are lots and lots of people who are more educated than you who have the misunderstanding of thinking that it is atrial contraction that causes the AV valves to open. But it is not atrial contraction that causes the AV valves to open. Anybody know what it is? Yeah, it's venous return increasing pressure on top of the AV valves, right? It's just continual venous return increasing pressure on top of the AV valves. That causes the atrioventricular valves to open. If it didn't, I would be dead because I have atrial fibrillation, right? If I needed the atria to contract dependably in order to open the AV valves, I would have had a heart attack or a stroke by now, right? So what actually causes the AV valves to open is venous return increasing pressure, right? Which will cause the AV valves to open. When the AV valves open, you start what stage again? Ventricular filling, right? But what happens at the end of ventricular filling in a healthy person is atrial contraction. So you get 80% of the blood that goes from the atria to the ventricles without atrial contraction. But in order to get a good stroke volume, you better get the rest of it in there, right? Does that make sense? So with me, when I'm in AFib, what happens is I get most of the blood in here, right? But this last 20% really doesn't go in. What does that do to my stroke volume? Drops it. What happens to my heart rate to compensate? Goes crazy. Does that make sense? Okay, so what we're going to do is we're going to go through the animation to watch him describe. He doesn't start right here. It doesn't matter, right? You can start anywhere you want, but I want you to try to figure out where he starts in the story. You ready? Okay, so.
Causes the atrioventricular valve. Ventricular contraction causes the atrioventricular valves to close.
Okay, try to figure out where you are in the cycle. What? Not ventricular filling. Mm-mm. Nope, we're not in ejection yet. Look at the position of all of the valves. Isovolumetric ventricular contraction. So I am right here in the story, right here, right? Okay, isovolumetric ventricular contraction. Before he goes any further, tell me how I'm going to end this particular stage. Semilunar valves are going to open, beginning what stage? Ventricular ejection. Okay, let's see it.
Which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole.
So that is in isovolumetric ventricular relaxation, yes? So I did isovolumetric ventricular contraction, ventricular ejection, right? Isovolumetric ventricular relaxation. Next question. How is this stage going to end? AV valves open, which will start what stage? Ventricular filling. Good.
Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling.
Okay, what's going to happen at the end of ventricular filling? Not when ventricular filling is over, but at the end of the stage of ventricular filling. Atrial contraction, right? Atrial contraction is part of ventricular filling, yes? Okay.
The atria then contract and complete the ventricular filling.
Isovolumetric ventricular contraction, ventricular ejection. Isovolumetric ventricular relaxation, ventricular filling, over and over and over and over again. Okay. Do you think that you would have to memorize what the valves are doing in each of the stages, or could you figure it out because you actually understand? So if in the isovolumetric ventricular anything, what's the position of the valves? Closed. They're all closed, right? With ventricular filling, what's the position of the AV valves? Open. So what's the position of the semilunar valves? Closed. With ventricular ejection, what's the position of the AV valves? Closed, because the semilunar valves are open, right? So it's a little logic story, yes, right, that you already understood most of the parts of, right? Okay, so let me just ask you a couple questions about this. First, I want to tell you that the heart sounds actually correlate to this. And the heart sounds, do you guys know the lubbed up, lubbed up, lubbed up? The lub is when the AV valves close and you can hear the blood slamming against it, right? So the AV valves closing will, of course, happen right here, right? Right here. So with isovolumetric contraction, and so you can see the heart sound happening right there, the lub. And the semilunar valves are going to close right here, okay? And so then you'll get the DUP. So the DUP is the blood slamming against the semilunar valves as they close, right? And it's higher and more staccato. And so the lub has to happen before the DUP, right? In each cardiac cycle, the AV valves close before the semilunar valves open and then close, right? Okay, so let's ask just a couple of questions to reinforce this. So actually, let's talk about the timing and then we'll ask a couple of questions. So the timing at a heart rate of 75 beats per minute, which is a little fast, but it's within normal. That gives you about 0.8 of a second for each cardiac cycle. So how much time do you spend doing each thing? You spend about 1/10 of a second with your atria contracted and your ventricles relaxed. So notice that atrial contraction isn't super long, right? And then you spend about 0.3 of a second with your atria relaxed and your ventricles contracting. So that's way longer, right? That's during ventricular ejection when you would be doing that isovolumetric ventricular contraction and ejection. And then please note that you spend about half the time with all of your chambers relaxed. So for each cardiac cycle, the relaxation is just as important as the contraction. So as long as you're healthy, no matter how high your heart rate gets, you spend about half the time contracted and half the time relaxed. Okay. So last little tidbit is simply this. I want to see if you guys can put together the stuff that you learned in lab, just a little teeny bit of it, about EKGs or ECGs together with this story. So you learned the P wave, right, and the QRS complex, right? And T wave, but the P and the QRS complex are going to be the important part here. So what I want to know is for each electrical event that you record on an EKG, can you figure out which mechanical event would follow it, right? Okay, so the electrical event is atrial depolarization represented by the P wave, yes? Okay, the mechanical event that is caused by that atrial depolarization is what? Atrial contraction. Okay, now here's the question. Does that mechanical event cause the opening or closing of any valves? Does atrial contraction cause the opening or closing of any valves? No, it does not. Okay? Okay, good. Now let's do the next one. The electrical event is ventricular depolarization this time, represented by the QRS complex. Yes? Okay. The mechanical event that is caused by ventricular depolarization is what? Ventricular contraction. Does the pressure generated because of ventricular contraction cause the opening or closing of any valves? The pressure generated by ventricular contraction cause the opening or closing of any valves? Yes. Which ones in what order? AV valves close, pause, then semilunar valves open. Got it? Everybody good? Okay, so that's putting that all together for you, all of that contraction and relaxation. Everybody okay with that? Okay, so I'm not going to test you over any of the patho on cardiovascular system. I would read through it because it's interesting, but I am going to spend our last 2 minutes and show you something adorable. I'm not going to test you over this either, but we're all a little stressed out and you got a test on Thursday, so here we go. You ready? These are two super nerdy. Okay, have you seen this? Where's the sound? Oh, we showed you guys this? I showed it to him, jerkbag. Wait.
Show us the extended version.
Where is it? Where's the... Oh. Let's see. It won't work if we don't have the music. Oh, balls. Who can tell me what I'm doing wrong? I know it was playing sound. Oh, you guys won't. Oh, you won't have to get... I can't show it to you now. Okay. I'll just link it for you. It's adorable. The top arm, the arms are the atria and the legs are the ventricles. Oh, wait. Oh, it contains a copyrighted audio track, jerkbags. So they had to, what? What?
That's what you get.
That's terrible.
Isn't that a lecture from
Is it from before? My son, my little boy on Halloween was in a dragon costume and he was dancing to hit the quan. You guys know hit the quan? He was dancing to hit the quan, and my husband tried to post it, and they kept taking it down. I was like, this is an 11-year-old in a dragon costume. They should be able to hit the quan. Okay, so I will see you guys on Thursday. It will probably be at least 60% endocrine, because endocrine you spent much more time on, okay? And if you don't know thyroid hormone, you will flunk it. Don't flunk it, okay? I want you guys to do well.